let's jump right into this explainer. Look, if you're managing neurological recovery, you already know B12 deficiency absolutely wreaks havoc on the spinal cord. It's bread and butter. But what happens when your treatment is clearly working, but the MRI insists your patient is still sick? Today, we're decoding a really fascinating clinical phenomenon, the B12 spinal recovery lag. Picture this classic clinical paradox. You're on the wards, your patient is walking better, their ataxia is clearly fading, but then you get the week A MRI back, and the spinal cord is still lighting up bright on the T2 sequence. So what's your next move? Do you stop treatment? Do you suddenly switch the diagnosis? Or do you just hold your nerve? Well, by the end of this explainer, you'll know exactly how to read this radiological lag so you don't make a critical error in patient care. So here is our roadmap for today. We'll start with the clinical MRI paradox, move into the 4 phases of reversal, discuss radiological and biochemical monitoring, tackle some clinical pitfalls and workarounds, and wrap up with high-yield pearls. Okay, section 1, the clinical MRI paradox. You are looking at the physiological lag in action right here. Notice how clinical function, that's the green curve, just shoots up between weeks 2 and 4 as the patient's symptoms rapidly improve. But the MRI resolution curve, it stays completely flat until around week 8. Why is that? Well, early on in treatment, water actually gets trapped between the myelin layers, which generates a persistently high T2 signal. That signal isn't going anywhere until late-stage structural compaction happens. So the golden rule, the absolute clinical imperative here, is that clinical improvement always precedes MRI normalization by 4 to 8 weeks. Basically, if they're walking better, the cord is healing, period. Moving on to section 2, the 4 phases of reversal. To really grasp this lag, we've got to zoom into the cellular level. In phase 1, the biochemical repair phase, during the first couple of weeks, B12 enters the cells and methionine synthase reactivates. Boom. By phase 2, which is weeks 2 to 6, we get axonal stabilization. Neuronal firing normalizes, and that's what drives that rapid clinical improvement you see right at the bedside. But pay attention to phase 3 here. Myelin resheathing doesn't even start until weeks 6 through 16. That is the exact moment when the trapped water content finally drops and the T2 signal fades. And then finally, phase 4 brings structural consolidation from months 3 all the way to 12, which completes the whole remyelination process. Now, the absolutely critical window here is 3 months. Time is literally cord. On one side, you have healthy remyelination, but on the other, you're facing irreversible reactive gliosis. To secure complete recovery for your patient, you have to initiate treatment under 3 months and look for rapid MMA normalization. On the flip side, starting treatment past the 6-month mark or seeing an AP cord diameter of less than 7 millimeters on a baseline T1 scan, man, those are massive predictors of a permanently stalled recovery. All right, section 3, radiological and biochemical monitoring. When you're ordering your serial MRIs, remember that 3T is vastly preferred over 1.5T. You really need that higher resolution to catch those faint, early treatment responses. And you specifically need 4 sequences. First, sagittal T2 to watch the cord signal fade out craniocaudally. Next, axial T2 to watch the classic inverted V shrink. Then there's stir sagittal, which is absolutely crucial because it's super sensitive to early edema and actually normalizes way before the T2 does. And lastly, grab a T1 sagittal to assess for any cord atrophy. Let's watch that classic V sign fade. At week 0, right at baseline, you have this full, bright, inverted V sitting there in the bilateral posterior columns. Fast forward to week 6 to 8, the steer is normalizing and the hyperintensity is shortening distally. By month 3, you can barely see it. And if you intervened in time, by month 6, that V is cleared entirely with 0 remaining atrophy. So because we know the MRI inherently lags behind, checking methylmalonic acid, or MMA, is literally your ultimate truth teller. Serum B12 just isn't enough. You need to see a falling MMA to prove the B12 is actually doing its job inside the cell. Tracking these levels is key. Baseline usually starts high, often well over 700. But by weeks 4 to 6, that number should absolutely plummet, getting close to normal by month 2. If the MMA completely fails to drop by week 8 despite IM B12 therapy, consider that a giant clinical red flag. You need to stop and rethink your diagnosis. Think multiple sclerosis, copper deficiency, or even syphilis. Which brings us to section 4, clinical pitfalls and workarounds. Look, we all know the reality of practicing medicine. 3T MRIs aren't always available, they're super expensive, and honestly, patient compliance often drops off. So what are the real-world workarounds? First up, the clinical hack. Doing Romberg and vibration testing at every single visit. It's completely free, it's highly sensitive, and it tracks axonal recovery perfectly. Second, the biochemical hack. Checking MMA and homocysteine at 4 and 8 weeks. That proves you're getting a tissue-level response for just a fraction of the cost of an MRI. And finally, if you absolutely must restrict imaging, just stick to the bare minimum: a day 0 baseline scan and a month 6 scan. Just skip all those intermediate MRIs entirely. You've got to avoid these 5 monitoring mistakes. Number 1, stopping B12 just because the MRI normalizes. Remember, pernicious anemia requires lifelong therapy. Number 2, declaring treatment failure at week 8 based on a bright scan. We just talked about this, remember the lag. Number 3, failing to get a day 0 baseline scan. Without that baseline, you are flying blind. You literally can't interpret any future scans. Number 4, and this one is absolutely critical, ignoring a clinical decline just because the MRI looks improved. Listen, dense scar tissue replacing demyelination can artificially lower that T2 signal. You always trust the physical exam over the scan. And number 5, relying entirely on low-resolution 1.5T MRIs. Okay, let's wrap this up with Section 5, high-yield pearls. Tracing a typical 12-month patient journey really pulls all of this together and shows how these markers sequentially fall into place. On day 0, you've got an ataxic gait and that full inverted V on imaging. By weeks 4 to 6, you start seeing those early clinical wins. The Romberg study's out and the MMI plummets. Then at week 8, you finally get your first MRI change as the sagittal signal shortens. Fast forward to month 6, you're seeing near full radiologic resolution, and the patient is probably heading back to work. And by month 12, it's all about lifelong functional maintenance. Now, if you're prepping for the boards, whether that's the USMLE or NEET PG, you need to commit these to memory. The first clinical sign of recovery, energy return usually right around day 7 to 14. Sequence sensitivity, STIR normalizes way before T2. The irreversible marker you're looking out for, cord atrophy of less than 7 millimeters AP diameter on that baseline T1. And your big red flag, if new serial lesions start popping up, stop thinking subacute combined degeneration immediately and start thinking multiple sclerosis. Let's look at this classic multiple choice question because it perfectly tests our core thesis today. So, a patient treated for 8 weeks has improved gait and a drastically dropped MMA. However, the repeat MRI still shows posterior column signal. What's your next step? The answer? Continue current therapy. You do not stop, you do not switch drugs. The physiological lag means the cord is actively healing, it just hasn't fully expelled the trapped water content yet. Hold your nerve. I want to leave you with this final thought. MRI clearance does not mean metabolic independence. We have this incredible technology to peek inside the human body, but at the end of the day, those scans are just delayed reflections of biological reality. The next time you're on the wards faced with a conflicting clinical picture and a stubbornly bright scan, ask yourself, are you treating the scan or are you treating the patient? Trust your exam, respect the lag, and we'll see you in the next explainer.